All right, so assalamu alaikum everyone. My name is Haleema Shafiq. I'm a fourth-year medical student, and I will be talking to you today about the topic bilirubin, metabolism, and jaundice. So this is an extremely important topic, okay, because not only are you going to see it in first year, but you're also going to see it in GIT third year, you're going to come across it in fourth year during your clerkships, and of course, you're also going to see it in your clinical practice, okay? So it's an extremely important topic. So we're going to start off by talking about bilirubin metabolism, okay? So it's important to know the difference between bile and bilirubin, okay? Bilirubin is a component of bile, okay? So conjugated bilirubin plus bile salts, phospholipids, cholesterol, and water, they all mix together to form bile. And bile is needed for the emulsification and digestion of fats, okay? So there is a difference between these two molecules. And it's important to understand what that difference is. So bilirubin, what actually forms bilirubin? Okay, the main source is heme, okay, which comes from hemoglobin in the red blood cells. So the average lifespan of a red blood cell in an adult is around 120 days, okay, after which they are broken down. And so once they are broken down, the hemoglobin, specifically the heme, is taken, okay, and broken down to form bilirubin. There are other sources of bilirubin, particularly myoglobin, which comes from muscles, and then of course cytochrome enzymes, which come from the liver, okay? But the main source that you need to know is heme. So this is the anatomy of a hepatic globule, okay? And what I want you to focus on is okay? The branch of the hepatic artery and branch of the portal vein, okay? So the portal vein basically carries blood, okay? It has the blood from the whole gastrointestinal tract, okay? Any food that you eat, okay? The nutrients that are broken down, okay, they get absorbed into the portal vein. And so this branch here of the portal vein basically is carrying all the blood from the gastrointestinal tract. So although it is deoxygenated blood, it has a lot of nutrients. This is the hepatic artery, okay? And of course, this carries oxygenated blood from the heart into basically bringing it to the liver. Now you can see here that this is something we call as sinusoids, and the blood from the portal vein and the blood from the hepatic artery are actually mixing, okay, together. And so if you look at it in more detail, okay, this is actually from your slides, okay, you can see here that the blood is mixing together in the sinusoids. Now, if you look at the sinusoids in a bit more detail, what you see here is that these are endothelial cells that are lining the sinusoids, and they actually have gaps between them, which we call as interendothelial gaps, okay? So the plasma that is running in the sinusoid is able to enter from the sinusoid into the perisinusoidal space, which essentially is the space between the sinusoids and the hepatocytes. These are the hepatocytes. And notice that they have microvilli. The function of the microvilli is basically to increase the surface area of absorption, okay? So that the nutrients which are present in the blood in the hepatic portal vein get absorbed easily. Okay, what you're also seeing here is Kupffer cells, okay? Kupffer cells are a type of macrophage. And the reason why they're here is that they're basically patrolling the sinusoids. They're looking for, like, let's say any foreign object, any foreign like toxins, pathogens, and also senescent or old red blood cells, okay? Because if those cells are old, okay, they're going to be broken down by the Kupffer cells, and the heme is going to be taken out to form bilirubin. Okay, it's important to know the difference. All right, so once the macrophage takes the heme, okay, what does it do with it? The heme is converted into biliverdin, okay, by an enzyme called heme oxygenase, okay? Then, once you have biliverdin, which is green in color, it is going to be converted into bilirubin, which is brown or yellow in color. And this is done by biliverdin reductase, okay? What's important to know is that bilirubin here is what we refer to as unconjugated bilirubin or indirect bilirubin. Okay, and this is hydrophobic, or you could say lipid soluble, which means that it's not going to be able to be transported in the bloodstream by itself. It requires a transport molecule, which here is albumin, okay? And so the unconjugated bilirubin binds to albumin, okay, and then is transported to the liver for further processing, okay? So not only Kupffer cells, okay, which are of course present in the sinusoids, but other macrophages as well, like for example, those present in the spleen or those present in the bone marrow, okay? All of those macrophages are going to carry out this reaction where they're going to take heme and convert it into bilirubin, okay? And so all that bilirubin is going to be collected together, bound to albumin, and then transported to the liver, okay? So what happens when it reaches the liver? The reason why we call it an unconjugated bilirubin right now is because the conjugation reaction hasn't happened. And conjugation essentially is when you add one molecule to another. So in our case, you're adding glucuronic acid to the unconjugated bilirubin. Now, referring back to organic chemistry as well as biochemistry, you know that these are hydroxyl groups, okay? And they're, of course, hydrophilic. So once you add those to the unconjugated bilirubin, you are making it hydrophilic or water soluble, okay? And when this molecule gets added to the unconjugated bilirubin by the enzyme UDP glucuronide transferase, we refer to it now as conjugated bilirubin, okay? Now, this is a really important enzyme, okay, and you need to remember it. It's going to come up a lot in the pathologies that we're going to discuss later on. So, conjugated bilirubin, once formed, okay, now it's going to form bile, which we discussed basically is formed from conjugated bilirubin, bile salts, phospholipids, water, cholesterol, okay? Now, once bile is formed in the liver, it's going to get secreted into the second half of the duodenum via the ampulla of Vater, okay? Along with the pancreatic secretions. So, just a quick review of the anatomy. This is the liver, okay? This is the gallbladder. This is your common bile duct. So once your bile is formed, it's stored in the gallbladder. And once it's time for it to be secreted, it's going to go from the gallbladder into the common bile duct. This is your pancreas, okay? And this is the main pancreatic duct, which of course has the pancreatic enzymes like amylase, lipase, zymogens, okay? And those are going to be secreted, okay, as well. Now they're going to reach the ampulla of Vater, which essentially is like a dilatation, where these two secretions, basically the bile plus the pancreatic secretions mix together, okay, and then they are secreted into the duodenum. The sphincter of Oddi surrounds the ampulla of Vater, okay, and it's basically a layer of smooth muscle cells, okay, and it allows the regulation of the secretions, okay? So when are these going to be secreted? When are they not? That's going to be controlled by the sphincter of Oddi. It's a layer of smooth muscle cells. So once the bile is secreted into the duodenum, okay, the conjugated bilirubin inside the bile undergoes two further reactions. Now, there is bacteria inside your duodenum. We call this the normal flora of your intestines, right? What it's going to do is that it's going to convert the conjugated bilirubin back into unconjugated bilirubin, okay? So it's basically going to remove that glucuronic acid molecule. And this is going to be done by the bacterial enzyme beta-glucuronidase, okay? Once you have the unconjugated bilirubin, that is now going to be converted into urobilinogen. Okay, this is also a really important molecule. So, once you have the urobilinogen formed, okay, it has one of two fates. The first is that it can be excreted in the feces by being converted into stercobilin, okay? And stercobilin is what gives your stool its brown color. Now, 80 to 90% of the urobilinogen that is formed is actually going to be going through this fate, okay, where it's going to be secreted in the feces as stercobilin. So around 10 to 20% of what's left, okay, is going to be reabsorbed by the intestines. 90% of what is reabsorbed, okay, is going to be taken up by the liver via the enterohepatic circulation. So like entero is the intestines, and hepatic, of course, is the liver. Okay, so the connection between them, okay, the circulation, is going to be taken up by that back into the liver, okay? While a very small amount is excreted in the urine as urobilin, okay, around 10%. And urobilin is basically what gives the urine its yellow color. So notice here how both in stercobilin and urobilin, it kind of ends in the ilin, okay? This name indicates that this is a colored compound, whereas urobilinogen, which ends in inogen, basically indicates that this is a colorless substance, okay? This is going to help you remember a little bit. So summary of everything that we've talked about so far, there is heme, okay, present in the hemoglobin in the red blood cells, okay? That is taken by the macrophages and it's converted into bilirubin, specifically unconjugated bilirubin. It's bound to albumin because we talked about how this is hydrophobic. And then it's going to go to the liver. Once it reaches the liver, it's going to become conjugated, okay? And this is done by the enzyme UDP glucuronyl transferase, which is a really important enzyme. Okay, now what you have is what we call as conjugated bilirubin, and this is water soluble or hydrophilic. Now, this conjugated bilirubin basically forms bile and then is secreted into the duodenum. Then the GI bacteria convert it into urobilinogen, okay, and then we talked about how it has two phases. The first one is that it's secreted into the feces as stercobilin and gives the feces its brown color. Around 10 or 20% is absorbed, okay, reabsorbed by the intestines, okay? Now, 90% of that goes back into the liver, around 10% goes into the kidneys, and basically gives the urine its yellow color as urobilin. This is again a summary slide. So this was mentioned in your presentation, so I thought we'd just go over it really quickly, okay? So what are the functions of the cells in the liver? So the hepatocytes, okay, they form bile canaliculi, which are over here, right here. Okay, these are bile canaliculi, and eventually they fuse to form the common bile duct. The hepatocytes, of course, also form bile acid. They form bilirubin, okay? The conjugation reaction happens in the hepatocytes of the liver, okay? Drug detoxification, metabolism of nutrients. We talked about how the portal vein is bringing blood from the whole gastrointestinal tract, and it contains the nutrients from the food that you eat, okay? Regeneration, so the liver has a special feature where if it gets injured, okay, it's able to regenerate itself by producing something called the hepatocyte growth factor, okay? Then there are, okay, before we go to Kupffer cells, drug detoxification is an important function of liver, okay? And the reason why is that when you study pharmacology, you'll see that some drugs are actually metabolized or broken down by the liver, and some are actually broken down by the kidneys, okay? So the reason why it's important to know that A, it is a function of the liver, and B, which drugs are metabolized by the liver is because let's say you have a patient who has a disease of the liver, okay? Let's say they have cirrhosis, for example. So this means the liver is not at its optimal state, okay? It's not functioning to its maximum capacity. So you don't want to give this patient a medication that is metabolized by the liver because the liver is not at its optimum state. It won't be able to break down that medication, and that medication will start to accumulate in the patient's body, reaching toxic levels. So instead of actually helping the patient, now it's become toxic and is now harming the patient. So that's why you need to know that drug detoxification is a function of the liver, and also which medications are broken down by the liver. Coming to Kupffer cells, we talked about how they are a type of macrophage and they basically help in the formation of unconjugated bilirubin. Okay. Stellate cells are required for fat storage and vitamin A storage, and they also produce collagen after injury. Endothelial cells, we talked about how they have interendothelial gaps here, which allow the plasma to easily come into the perisinusoidal space and allow for the nutrients to get absorbed. Now, an important feature is that there is no basement membrane, okay? You don't see a basement membrane here. And the reason why this is important for you to know is that the hepatocytes, okay, are responsible for producing albumin, which is a protein, right? Now, albumin is actually extremely large in size. And so if there was a basement membrane, it would actually not be able to enter the sinusoids. And the reason why there is no basement membrane is to basically allow the protein to go from the hepatocytes into the sinusoids. And here it's very highly permeable to proteins because the endothelial cells have these interendothelial gaps, which allow large molecules like albumin, okay, to go from the hepatocytes into the sinusoids. So we are done with bilirubin metabolism, okay? We've discussed a lot of things, and essentially now we are done with the physiology. Now we're going to move on to the pathology, which is jaundice, okay? So I'm going to quickly check the chat if there are any questions. Okay. Moving on to the pathology. So jaundice. Now, in order to understand pathology, you actually need to understand the physiology. So we've discussed that already. And now it should be easy for us to figure out why stuff is happening the way it is in jaundice. So what is jaundice? It's a yellowish discoloration of the skin, sclera, mucous membranes because of the deposition of bilirubin. The types that we're going to be discussing, okay, are physiologic, congenital jaundice, okay, prehepatic and posthepatic jaundice. So, physiologic jaundice is actually the most common cause of neonatal jaundice. And it's basically a physiological rise in unconjugated bilirubin because of mainly two things. The first is that the fetus, okay, or the infant has a very short half-life, short lifespan of the red blood cells, okay, around 60 to 90 days. An adult, okay, the red blood cell of an adult, the lifespan is around 120 days. And the second is that there are immature hepatocytes. So not only are the red blood cells being broken down quicker than they would in an adult, but also the hepatocytes are not used to processing the unconjugated bilirubin. So you have immature cells and you have a lot of indirect or unconjugated bilirubin. That is why there's an increase in the indirect bilirubin, okay, which is why you have the jaundice. And physiologic jaundice is harmless, and it occurs in most infants between the 2nd and 8th day. So it's a rise in indirect bilirubin, but it is not a problem, okay? And usually it resolves by itself because the hepatocytes quickly start to mature, and they're able to handle all of that increased unconjugated bilirubin. Coming to congenital hyperbilirubinemia, okay? So you divide it into unconjugated and conjugated hyperbilirubinemia. So under unconjugated, there are three, okay, which are extremely high yield and what you have to know for your exam. There's Gilbert syndrome, Crigler-Najjar syndrome, type 1, and type 2. There's also hemolytic diseases, okay, and we will go over it briefly, but the high yield ones are these three, okay? Under the conjugated hyperbilirubinemia, okay, there is Dubin-Johnson syndrome and Rotor syndrome. So we're going to discuss all of these. So just to get hemolytic disease out of the way, okay, essentially if a patient has a type of hemolytic disease, which includes sickle cell disease, glucose 6-phosphate deficiency, or hereditary spherocytosis, and all of these diseases, basically, there is an abnormality or a pathology in the red blood cell, okay, which means that instead of being broken down after 120 days, they get broken down earlier than that, okay, because they have that abnormality in them. So again, because there is so much breakdown of the red blood cells, there is a lot of unconjugated bilirubin that is produced. And so the liver gets overwhelmed, and which is why these patients end up having jaundice, because the liver is not able to process all of that unconjugated bilirubin into conjugated bilirubin. So I wrote down a little bit details about each of these diseases. If you want to go on, basically go over it by yourself, you can. But it's not very high yield for you to know, okay? Mainly what you need to know are the three we're going to talk about right now. So Gilbert syndrome, okay, what happens here is that there is a mutation in the enzyme called UGT-A1. There is a mutation in the gene UGT-A1, okay, and this gene codes for the enzyme UDP glucuronidyltransferase, which, like I mentioned, is an extremely important enzyme. So because of this mutation in the UGT1A1 gene, the activity of this enzyme decreases. So the unconjugated bilirubin is not converted into conjugated bilirubin, okay? And this means that, let's say, if the patient undergoes any sort of stress, like a trauma, illness, or exhaustion, where their body needs, let's say, more nutrients, more energy, the liver is going to become preoccupied with basically breaking down macromolecules and releasing energy. And it's not going to be able to convert the unconjugated bilirubin into conjugated. And because they have this mutation, okay, and they have a defective enzyme, once the liver becomes preoccupied with something else, basically the levels of indirect bilirubin will increase and they're going to have jaundice. The same thing happens in fasting periods, okay, because the liver becomes preoccupied with basically breaking down macromolecules to release energy, and it doesn't have time to convert indirect to direct bilirubin. So this wouldn't be a problem if the enzyme was fully functional, but because it isn't, that is why these patients end up having jaundice. Alcohol consumption, basically alcohol is broken down by the liver. So it's kind of the same pattern here, that if the patient drinks a lot of alcohol, the liver needs to break down and metabolize that alcohol to prevent it from becoming toxic. And again, they have a deficient or defective enzyme, and so they end up having jaundice. The onset of this disease is usually during adolescence, and they might be asymptomatic or have unspecified symptoms, such as fatigue and loss of appetite. They usually end up having a mild jaundice, but it can range from like mild scleral jaundice to having a generalized jaundice. One way to remember Gilbert syndrome is your the mnemonic UGT. So unconjugated essentially means this is a type of unconjugated hyperbilirubinemia, and G is for Gilbert. The UGT1A1 is basically the gene that is mutated, okay, and it codes for this enzyme. And this is the third part, UDP glucuronide transferase. So, quick recap, in Gilbert syndrome, UGT1A1 gene is mutated, which means this gene, the activity of this enzyme decreases, and there is an increase in indirect bilirubin. That is Gilbert syndrome. So Crigler-Najjar syndrome has two types. There's type 1 and there is type 2, okay? The UDP glucuronide transferase enzyme is completely absent, okay, in type 1, okay? And therefore, these individuals are unable to convert unconjugated to conjugated bilirubin because this enzyme is absent, okay? So they can't carry out that reaction. So what you're going to see is persistent neonatal jaundice. If you recall, in physiologic jaundice, it usually resolves by itself around the 8th day, okay? But these neonates, okay, it's not going to go away. And so you're going to figure out, okay, there might be an underlying pathology. There's also something called as kernicterus, okay? Kernicterus is basically the unconjugated bilirubin. It goes and starts depositing inside the brain, okay? And it results in cerebral paresis, okay, which is partial loss of the voluntary muscle motor control, hearing impairment, and vertical gaze palsy. So these patients are not going to be able to move their eyes up and down completely, okay? There's going to be limitation in that movement. There's also going to be choreoatetosis, which is basically quick involuntary movements of the hands and feet. You can put this on YouTube and you'll see exactly what this is. But essentially, what kernicterus is that the unconjugated bilirubin, it starts to go and gets deposited in the brain, okay? And that, of course, has complications. So diagnosis of Crigler-Najjar can basically be made by measuring the levels of indirect bilirubin, and you're going to see that they're going to be extremely elevated, okay, around 20 to 50. But you're going to have normal liver function tests, and we're going to discuss this in detail towards the end of the lecture. But essentially, a normal LFT means that there is no damage to the kidney, okay? And there's going to be no signs of hemolysis because, again, hemolysis could also lead to extremely high levels of indirect bilirubin. But when you carry out the lab test and you don't see any signs of hemolysis, this means that this is not the pathology that's causing these high levels. And so you have to look for something else. Okay. Crigler-Najjar syndrome type 1 does not respond to phenobarbital. Okay, this is a medication which you could give to patients who have Crigler-Najjar syndrome type 2, and we'll discuss that later on. But you need to know that they don't respond to phenobarbital because this is actually supposed to stimulate the UDP enzyme. But these patients don't have it, it's completely absent. So there is nothing to stimulate, okay? And liver transplant is the only cure for these patients. In type 2, there are reduced levels of the UDP enzyme, okay? So in contrast to type 1 where it was completely absent, here it is present but in a small amount, okay? And so the unconjugated bilirubin levels are elevated, but they are not as high as type 1 because some of it is again being converted into conjugated bilirubin by the liver. It's often asymptomatic and there's no neonatal jaundice. There will be no neurological symptoms because, like I said, the levels of the indirect bilirubin are not going to be very high. So these patients will not or are less likely to develop kernicterus. Diagnosis here is that indirect bilirubin levels are less than 20, and again, normal LFTs and no signs of hemolysis. If you give patients phenobarbital, they're actually going to respond to it because phenobarbital induces this enzyme, so increases its activity. So although you have a less number of enzymes, because you're going to increase their activity, it's going to help these patients, okay? The way you can remember it is by knowing phenobarbital, okay? So phenobarbital is given to patients who have Crigler-Najjar syndrome type 2. So this is a pretty good table which summarizes the difference between type 1 and type 2 Crigler-Najjar syndromes, okay? So quick recap, pathophysiology of type 1, it is completely absent, okay? Which means like elevated and extremely elevated indirect bilirubin levels, which leads to kernicterus, which is the deposition of indirect bilirubin into the brain, resulting in cerebral paresis, where the patients lose motor control, partial loss of muscle control, they have hearing impairment, they have limitation moving their eyes upwards and downwards, and they also have chorioathetosis. Treatment basically is liver transplant. They won't respond to phenobarbital. Whereas in type 2, the UDP enzyme is present, but in reduced number. And so there will be an increase in indirect bilirubin, but not as high as type 1. They're not going to develop kernicterus because some of it is being conjugated. And treatment is that, yes, they respond to phenobarbital. Coming to the conjugated hyperbilirubinemias, okay, this is Dubin-Johnson syndrome. And so the problem here is that there is a defective MRP2 protein, which is usually present here in this diagram, okay? The MRP2 protein is responsible for the secretion of the conjugated bilirubin out of the hepatocytes into the bile canaliculi, okay? And the bile canaliculi basically transport the bile into the common bile duct, okay? And then from that, it goes into the duodenum. But because it's a defective MRP2 protein, the bile is formed, but it just can't leave the liver, okay? And so these patients are going to have mild to moderate jaundice, and onset often occurs during adolescence. The diagnosis is going to be elevated levels of direct bilirubin, okay? Because when this bilirubin can't go into the duodenum, it's going to enter the bloodstream. When it enters the bloodstream and you basically measure the bilirubin levels, you're going to see an extremely elevated level of direct bilirubin. Now, because this conjugated bilirubin is accumulating inside the liver, if you do a liver biopsy for these patients, you're going to see a dark and basically granular pigmentations inside the liver because the bile is now accumulating inside, okay? So this is what you're going to see if you do a liver biopsy for patients who have Dubin-Johnson syndrome. And this is a really high yield point. Usually you will get this hint during your questions. If they're trying to hint you towards Dubin-Johnson syndrome, they will tell you that liver biopsy showed dark granular pigmentations on the liver. So in Dubin-Johnson syndrome, the liver appears dark. Rotor syndrome. So in Rotor syndrome, there is a defective OATP1B1 and OATP1B3 proteins, resulting in decreased transport and storage of direct bilirubin. So kind of similar to Dubin-Johnson, but there is a difference between what proteins are defected, okay? In Dubin-Johnson, it was the MRPT protein, and here it's the OAT1B1 and the OAT1B3 proteins. Again, asymptomatic but mild jaundice may happen. Presentation is milder as compared to Dubin-Johnson syndrome. So again, because the bilirubin is not able to leave the liver, it starts accumulating in the liver and then eventually also enters the bloodstream. Okay, and so if you measure the level of bilirubin, you're going to see increased in direct bilirubin levels. Normal liver function test, and if you do a liver biopsy, it's going to be normal and you're not going to see any pigmentation. So this is actually the differentiating factor between Rotor syndrome and Dubin-Johnson syndrome, because in questions, you might not be able to differentiate because, again, the LFTs are going to be normal, but you're going to see a very high amount of direct bilirubin. So they're going to give you the hint that the patient either has a dark and granular pigmentations on the liver or they have a normal liver. Okay, this might be your hint in the clinical vignette. So it's important to know. So in Rotor syndrome, the liver appears regular, whereas in Dubin-Johnson syndrome, the liver appears dark. Okay, so we've discussed physiologic jaundice and we've also discussed congenital hyperbilirubinemias. Now, we're going to move on to prehepatic jaundice and posthepatic jaundice, okay? So what I saw in your presentation is that you don't need to know intrahepatic jaundice, so we're not going to go into the details of that. We're mainly going to be discussing pre- and post-hepatic jaundice. So this is a really good diagram that discusses all of the three ones, okay? Pre-hepatic, mainly, could be because of hemolysis, okay, or ineffective erythropoiesis. And then post-hepatic could be because of cholelithiasis, inflammation, malformation of the biliary tract, tumors, bile duct strictures. Let's go into it to a bit more detail. So in pre-hepatic jaundice, okay, there's going to be an increase in the indirect bilirubin levels, okay? And why is that? It's because there is a problem before the liver starts to do anything, okay? And like the name suggests, it's pre-hepatic. So it's characterized by unconjugated hyperbilirubinemia because the bilirubin has not reached the liver yet, so it has not undergone the conjugation process yet. And this can happen because of increased hemoglobin breakdown. It's similar to what we talked about before, okay? There could be hemolysis because of G6PD, sickle cell disease, spherocytosis, or infective erythropoiesis, so thalassemia. There is an abnormality in the hemoglobin, okay? And similarly, in pernicious anemia, what happens is that there are auto antibodies against the parietal cells, which are responsible for producing intrinsic factor. Intrinsic factor is needed to absorb vitamin B12. Now, why is vitamin B12 important? It's because it's required for the production of heme. So if you don't have vitamin B12, you're going to have an abnormal heme molecule. And of course, that is going to be detected by your body, and those red blood cells with the abnormal heme are going to be broken down. Okay, and because the person has pernicious anemia, they're not going to be able to absorb vitamin B12 at all, and they're going to have a lot of abnormal heme in the red blood cells. So again, increased hemolysis because of ineffective erythropoiesis. Or there is just increased bilirubin production because let's say you have a patient who underwent a road traffic accident and they required blood transfusion because they lost a lot of blood. Now, if you give them blood transfusion, of course, you're giving them a lot of red blood cells. And if you're giving them more red blood cells, again, more breakdowns, so more bilirubin. Coming to posthepatic jaundice here, okay, like the name suggests, now you have reached after the liver. So the liver has performed its function of the conjugation reaction. So here you're going to see an increase in the level of conjugated bilirubin, okay? It's characterized by conjugated hyperbilirubinemia caused by extrahepatic cholestasis, which essentially means that there is either an impairment in the bile production or secreting the bile, okay? Because of, let's say, biliary obstruction. So causes can be malignancy, gallbladder and gallstone disease, or inflammatory. So essentially, in posthepatic jaundice, the bilirubin has now become conjugated, okay? But for some reason, you can't secrete it out of the liver into the duodenum. Let's say in malignancy, cholangiocarcinoma, it's a tumor in the biliary tract, okay, which more commonly occurs in the extrahepatic ducts. So there are some, let's say, hepatic ducts inside the liver, okay, and some of them are outside. So if there is a tumor in any of the biliary tract, it's going to prevent the bile from going from the liver into the duodenum, okay? And so if that happens, it's going to start accumulating inside the liver, and it's going to cause jaundice because that is going to go into the bloodstream, okay, the conjugated bilirubin. And yeah, it could also happen because of pancreatic cancer. So look here. This is the head of the pancreas. And let's say if you have a tumor in the head of the pancreas, it can obstruct the common bile duct, which prevents the bile from going from the common bile duct into the duodenum. Liver cancer, of course, affects the liver's ability to conjugate the bilirubin. Okay, so it's not necessarily an obstruction, but the inability to conjugate the bilirubin. Gallbladder and gallstone disease, cholelithiasis, is a stone in the common bile duct, okay? And cholangitis is inflammation of the biliary tract, okay? Inflammatory primary sclerosing cholangitis is a chronic inflammation of the intra and extrahepatic ducts, and why this happens is not known. But again, if they become inflamed, they're not able to transport the conjugated bilirubin into the duodenum. Okay. Now, Urobilinogen is an important molecule, okay, and you can measure the levels of urobilinogen in the urine, okay, and this can give you a hint about the underlying pathology. So let's say you take the patient's urine and you measure the urobilinogen levels and they end up being more than normal, okay? This means that there is excessive unconjugated bilirubin in the body, and this could potentially be because of, let's say, hemolysis. Or if it's less than normal, this means that there is low levels of conjugated bilirubin, which could be because of obstruction. Okay, so urobilinogen was formed from the unconjugated bilirubin by the bacteria. Okay, so keep that in mind. So we are done with jaundice. Okay, we discussed the physiologic jaundice, the congenital hyperbilirubinemia, then we discussed the pre and post-hepatic jaundice as well. Now, this was also mentioned in your slides, the metabolism of NSAIDs, and we kind of touched on drug detoxification and the function of the liver, okay? But this one was specifically mentioned, so let's go into a bit more detail about it. So NSAIDs are non-steroidal anti-inflammatory drugs, and they are used to relieve pain, okay? They're analgesics, and are one of the medications that are metabolized by the liver. So if a person were to take the normal dose of NSAIDs, okay, around 90% of it would go to phase 2, okay, and basically be converted into glucuronide and sulfate metabolites, okay, which are non-toxic. Okay, conjugation reaction happens where the acetaminophen, okay, which is paracetamol or the NSAIDs essentially, are converted into these metabolites, which are non-toxic by the enzyme glucuronide transferase, okay, which is good. They're non-toxic metabolites. But if, let's say, someone takes an overdose, okay, then this pathway is going to become overwhelmed, okay, and more of the acetaminophen or the NSAIDs are going to be pushed towards phase 2, which is an oxidation reaction by the CYP2E1 enzyme, and is converted into NAPQI, which is an oxygen-free radical. And this, of course, harms the body, okay? So if there is an acetaminophen or NSAID overdose, okay, this is going to happen. An oxygen-free radical is going to form and it's going to basically harm the patient. What you can do for these patients is give them an acetylcysteine. What this does is that it increases the GSH levels, which convert this oxygen-free radical into cysteine conjugates and mercapturic acid, which are again non-toxic. Okay, so acetaminophen toxicity is something that you're going to see in pediatric clerkships as well. It is one of the pediatric emergencies. So it's important to know basically how NSAIDs or how acetaminophen is metabolized. Okay, so serum markers of liver pathology. So what actually gives you a hint that there is something wrong with the liver and you need to do more investigations to figure out what is the underlying pathology, okay? Those are basically serum markers. You have AST, which is aspartate aminotransferase, and alanine, which is alanine aminotransferase, which is ALT, okay? Now, in most of the liver diseases, what you're going to see is that the ALT and the AST are both elevated. But specifically, in most liver diseases, the ALT is going to be more than the AST. However, specifically in alcoholic liver disease, so for example, if patient takes a lot of alcohol, consumes a lot of alcohol, of course, the liver is going to become damaged because the liver is responsible for the detoxification or the breakdown of alcohol. In those cases, you're going to see a high amount of AST and ALT, okay? If AST levels are elevated in non-alcoholic liver disease, this suggests that there's progression towards advanced fibrosis or cirrhosis, okay? Another enzyme is alkaline phosphatase, which is ALP, and this is going to be increased in cholestasis, for example, biliary obstruction. The bile can't come out of the biliary tree. Or infiltrative disorders or bone disease, okay? Now this is important, that is also elevated in bone diseases. Another enzyme called gamma-glutamyl transpeptidase is also elevated in various liver and biliary diseases, but not in bone disease. So let's say you see an elevated level of ALP, and you're not sure if this is because there's something wrong with the liver, or it's something wrong with the bone. So in that case, what you're going to do is you're going to perform, or you're going to check the level of gamma-glutamyl transpeptidase. If this is also elevated, then this means there's something wrong with the liver, okay? It's a hepatobiliary pathology. But if this is normal, this means it's a bone disease. So this kind of helps you differentiate. Functional liver markers, these substances basically are produced by the liver, okay? So if they are low in, if there are lower levels of these substances, this also indicates that something is wrong with the liver. So if these are elevated, this gives you a hint that there's a pathology. And if these are low, then it gives you a hint that something's wrong with the liver. So bilirubin. Bilirubin is increased in various liver diseases, example, biliary obstruction, alcoholic or viral hepatitis, cirrhosis, hemolysis, okay? So exception is the bilirubin here, but albumin and coagulation factors and platelets, of course, if they are low, then that means there's a liver disease, but not bilirubin, okay? If there's a liver disease, bilirubin is going to be high. And we talked about it in a lot of detail, so I feel like I don't need to go over it again. Albumin is, like we discussed, a protein produced by the hepatocytes, and we talked about the intraendothelial gaps and how it allows it to go into the sinusoids and everything. But if albumin levels are low, this means the liver is not producing it, okay? And this happens in advanced liver diseases. So it's a marker of the liver's biosynthetic function. If the liver is not producing albumin, that means there's a pathology. Prothrombin time essentially is when you measure how long it takes for the bleeding to stop after you make, let's say, like a cut or an incision, okay? So if it takes more time than normal, this means the patient does not have coagulation factors because those are supposed to stop the bleeding. And coagulation factors are produced by the liver. So again, in advanced liver disease, the prothrombin time, which is the time it takes for the bleeding to stop, is going to be increased because there is a decrease in coagulation factors production. Platelets also are produced by the liver. So again, there's going to be a decrease in platelet levels in advanced liver diseases. So if albumin is low, if coagulation factors are low, and if platelets are low, this means the liver is not functioning to its optimum capacity. If bilirubin is high, again, this means something wrong with the liver. It's not able to carry out the conjugation reaction. So we are essentially done with this topic. Okay, now we're going to discuss some of the questions. So what to expect in your exam regarding this particular topic. So, an experimental device containing hepatocytes is developed to provide effective support for patients with hepatic failure, pending liver regeneration or liver transplantation. Hepatocytes viability is best documented by an increase in which of the following? So you have these options, and they're asking you, if you want to check if the hepatocytes are viable, what exactly are you going to measure, or what are you going to see an increase in, just going to give you that hint. So that would be albumin, because albumin is, again, one of the things that is produced by the liver. And we talked about how a decrease in its level indicates a liver pathology. So right here. So a 47-year-old woman presents to her primary care physician with jaundice, and she is found to have elevated levels of direct bilirubin. Which of the following is the most likely diagnosis? So here it's going to be obstruction of the common bile duct, because all of these are what? They are unconjugated hyperbilirubinemias. In Crigler-Najjar type 1, there is complete absence of the UDP enzyme, so conjugation reactions can't happen. In type 2, it's not absent, but it's like decreased levels are present of the UDP enzyme. So again, an elevation of the indirect bilirubin. In Gilbert, again, decreased activity of the enzyme. And hemolytic anemia, there is a lot of indirect bilirubin being produced because, again, red blood cells are being broken down. So this is your answer, that because she has direct hyperbilirubinemia, conjugation is happening, but the bile isn't able to come out. So there's an obstruction somewhere. Okay, a neonate has been persistently jaundiced from birth despite aggressive phototherapy and exchange transfusions. Lab studies demonstrate significantly elevated unconjugated bilirubin. Tests from an outside lab confirm the total absence of glucuronyl transferase activity, and this neonate most likely has which of the following condition? So here it's going to be Krogler-Najjar, specifically type 1, because there is a complete absence, okay? Total absence of the UDP enzyme. Okay, so this is a little bit difficult, one of the difficult questions. A 49-year-old man comes to the physician because of a 1-week history of yellowish discoloration of his skin and generalized pruritic skin. Examination shows jaundice of the skin and scleral icterus. Urinalysis showed an elevated concentration of bilirubin and a low concentration of urobilinogen. Which of the following is the most likely underlying cause of these findings? So here is basically defective hepatic bile excretion, and we talked about how if you see less than normal levels of urobilinogen, this basically means that there could be an obstruction somewhere, okay, which is why this is the answer. So we have reached the end of our topic. I hope you guys found this lecture helpful, and I hope this helps you in your exam. Kindly scan the QR code to give us feedback about the session. And if you have any other questions regarding the topic, you can reach me on my email or my number at any time. So, Assalamu alaikum.